and mentoring. So it's a truly a great honor, and I would reiterate, Dr. Baparaj is a dear colleague here at Michigan Medicine. We know each other for a long time, so it's great to be a part of this link. So thank you again, Dr. Nandan.
Thank you. You could start. You are the host now. You could start.
Okay. Let me share the screen.
Yeah.
Okay. Everybody see the screen?
Yeah, fine.
Okay.
It's
great. So thanks again. And as mentioned, I'm going to talk about acute emergencies in neurointervention, and the big one, the more prominent and conspicuous one, which recently has had the benefit of tremendous therapy and tremendous outcomes for patients with ischemic stroke. So we'll touch upon imaging of acute ischemic stroke and a little bit about the nuances. It's a very vast topic, so in a short time to cover all aspects is difficult, but we'll get a flavor of what we can achieve in patients and how we can select patients better. And then I'm going to talk also about vasospasm in subarachnoid hemorrhage. So that's another emergency that we get woken up in the middle of night at any time of day, that we can intervene and improve blood flow, perfusion to the brain that gets traumatized by vasospasm in patients who get subarachnoid hemorrhage. So moving on, so acute ischemic stroke. So it's an emergency that is faced by very commonly in departments all around the world, and workflow to identify these patients early, imaging them early to identify the cohort, which is large vessel occlusion. So as we can see here on the CT, non-contrast CT head, vessels at the base of skull, which is, if I can point my arrow, yeah, there we go. So at the base of skull, suprasellar cistern, where the circle of Willis that most of us will know, and more for trainees who are joining in on this talk. Middle cerebral arteries as they course laterally to supply all of the cerebral hemisphere bilaterally. So you're looking at hyperdensity in those vessels where acute clots will have hyperdense signs. On this particular patient, we don't see that specifically in the M1 segment. And here is the anterior cerebral artery going out to the midline, getting blood supply to the paramidline portion of the cerebral hemispheres. On this second image here, you can see what is termed, you will hear that in publications, in textbooks, talking about the insular dot sign. So here in the insula, or just overlying the insula, as I'm pointing out with the arrow, there is a hyperdense sign in the blood vessels. So suggestive of potential for clot in one of the branches of the middle cerebral artery, as the branch M1, which is called the horizontal branch, and then as it courses towards the insula, that is the second segment or the M2 segment. So this is a clot which is right at the junction of the M1 and M2 branches of the middle cerebral artery. So in any acute ischemic stroke, suspicion based on clinical grounds, as we see, the first port of call is to do a non-contrast CT head, and that is to exclude hemorrhage. You don't want to be giving patients clot-busting medication if there is hemorrhage as the etiology for their predicament of neural and functional loss, be it hemiparesis, be it speech loss, as we know from a presentation of acute ischemic stroke. So once we have excluded hemorrhage, we go on to be identifying how much is the damage. Can we assess on a non-contrast CT head, is there damage? Which side is affected? You may not get the density hyperdense sign in all patients, but if the clinical suspicion is high, on imaging, one has to look very judiciously. And here you can see on this image, on the on the right-hand side of the image, there is the caudate head bilaterally at the level of the lateral ventricles. And here on the left side, it is slightly lower in the ganglionic segment where the basal ganglia is located, where I'm pointing with the arrows. If it can be perceived, I don't know whether it projects that well on the screen here, but radiologists or astute neuroradiologists will pick up loss of gray-white differentiation. So white matter here in the basal ganglia is tightly packed in the internal capsule, and you have gray nuclei in caudate head, globus pallidus, and putamen, sort of identifying. You can see how it is well defined here on the left side of the brain. You have caudate head nicely seen, putamen, globus pallidus, the insular cortex, the so-called insular ribbon, and then thalamus. So here on the right side, you see it is a little vague, it's hazy. The definition is lost, not completely, but it's hazy. The posterior limb of the internal capsule is relatively well defined, but this area is fuzzy compared to the left. So this is an early sign, very early sign of ischemic stroke. And we have that insular dot sign as we saw, suggesting it is acute ischemic stroke, large vessel occlusion. What can we do? How can we salvage brain that is not affected? Here, it's starting to have effect in the basal ganglia. So this is what is evident on the, so non-contrast CT head is very, very important. It gives you some stratification of, okay, there is no hemorrhage, there is a large vessel occlusion, how much of brain tissue is already damaged and how much is at stake. That's that core and the penumbra, as we all hear about in acute ischemic stroke. Here is further up in the supraganglionic region. As you see, the other cortical structures, the gray-white differentiation is very symmetric. It's not affected. Caudate head, basal ganglia in the ganglionic region, it is affected, but not supraganglionic, which is reassuring, which means that there is a large amount of tissue that can be salvaged. That is, if you don't open up the vessel, it is probably going to get affected and there will be further neuronal functional loss. So this is what the scoring system is, the Alberta scoring system for non-contrast CT heads to get a score or an assessment which patients are favorable to undergo thrombectomy once the large vessel occlusion is identified or confirmed. So there is a lot of debate, and here the scoring system is, as we see here on the slide, it's from 0 to 10. A higher score is a good score, as a favorable score for the patient to undergo thrombectomy. There are currently debate going on and trials going on in this large core, moderate core area, whether these patients with large vessel occlusion are also candidates and can have benefit from intra-arterial endovascular thrombectomy techniques to recanalize the vessel. But it is very well established, and we'll go through, I'll touch upon the evidence that is there, that if the score is around above 7, 8 to 10, which means that at least maybe just 2 or 3 areas in the ganglionic region or in the supraganglionic regions are affected. So you subtract a score from a score of 10 where you see gray-white differentiation loss. So as we saw on the CT just now, the score there would be definitely above 7. It has probably got scores for the caudate head, which would be 1. And then we saw the posterior limb of the internal capsule, which is intact. So maybe lentiform nucleus will get another score off. So a score of 8 maybe. Insular ribbon in the anterior aspect also was a little ill-defined. So somewhere between 2 to 3. So definitely above 7. So very good candidate for thrombectomy. There is no hemorrhage, very good candidate for thrombectomy. So this is the next port of call. So if we get the aspect score from the non-contrast CT head, how do we identify? How do we confirm that there is a large vessel occlusion? So CT angiogram, very easily available. Now the CT scan resource is available across the world, very easily tapped into most hospitals, most emergency departments will have CT scans, CT scanners, which are capable of processing CT angiograms. So intravenous contrast is given, and timed bolus chased arterial phase scans are done to identify large vessel occlusion. So here we see in the same patient where we had the fuzziness in the basal ganglia. This is the ICA terminus, the A1 segment of the anterior cerebral artery. This is the A2 segments bifurcating off towards the paramidline portions of the cerebral hemispheres. The middle cerebral artery is well perfused here on the left side, but it comes to a hard stop, as we see here on the right. So suggestive of that insular dot sign is confirmed, yes, that it is a vessel occlusion, it is a large vessel occlusion, and the patient is favorable to undergo thrombectomy. So if this patient was within 4.5 hours of onset of stroke, then no other imaging is needed. There's a little bit of debate whether perfusion, some centers do perfusion scans on every patient that comes in. At our center, we don't do perfusion scans under 4.5 hours. The reason for that is that even if the brain is, we know in this patient, the brain is not damaged a lot, it's only in the basal ganglia region. But if the patient has a larger core, I think less than 4.5 hours, there is evidence that if you recanalize vessels, the patients will do better. So in that situation, we don't do CT perfusion. So CT perfusion or any type of perfusional assessment of a core and penumbra is done only when the patients present beyond 4.5 hours. So they don't have, or they're contraindicated to have tissue plasminogen activator intravenously administered, TPA as we know it. And we see here on the right side, paucity of perfusion of the left cerebral hemisphere, completely asymmetric compared to the right side. Okay, so this is, as we said, the port of call, CT perfusion. This particular patient had presented about 10 hours from last known normal. So in those situations, we would get CT perfusion. So CT perfusion is basically administration of intravenous iodine-based contrast and repeated scans of the ganglionic and supraganglionic region over about 30 to 35 seconds. So the span is about 8 centimeters, and that span of the brain above, below the ganglionic region to above in the supraganglionic segment is what is done to get assessment of how the blood flow is in the areas of brain that are stunned from the occlusion, how much is damaged and how much is salvageable. So this is now automated. There are several automated platforms that are there that most emergency departments and radiology departments have. And these basically software platforms process this data of plotting the increase of contrast in the tissue by regions and how much time it takes to peak, whether there is some pooling of contrast, and how do they wash out. So that is basically the parameters that are used are time to maximal contrast, cerebral blood flow, as we see here, CBF. So most of these platforms are based on cerebral blood flow data. If the cerebral blood flow in a region of brain is less than 30% of its normal, that is deemed to be a core tissue, as in neuronal cells are lost in there. They won't recover. So that is what is termed a core ischemia. So here we see on these images, the purple, if it projects out on the screen, this is the area. As we were seeing, it relatively matches with that ganglionic segment of gray-white differentiation loss that we were seeing on the non-contrast CT head. In the supraganglionic segment, you can see this whole bunch of green, which is salvageable tissue. That area is Tmax, more than 6 seconds, right? So 6 seconds is a transit time of a bolus of contrast or a segment of blood that is coursing through the blood circulation in the brain, from the arterial to the venous veins. So that 6 seconds, if it is crossed, that is oligemia, ischemia, potential loss of neuronal tissue. And then we basically match, or the software computes the ratio between core tissue and oligemic and salvageable penumbral tissue. And evidence suggests that if the ratio of, or that mismatched volume of penumbra to core exceeds 1.8, that is to say that if roughly the penumbra is double of the core, it is a favorable situation to go for endovascular thrombectomy. And here, obviously, the mismatch ratio is sky high. These are other parameters that can be computed as well. The Tmax more than 10 seconds, 8 seconds, 6 seconds, and 4 seconds. So this is flavors that are being researched now as to how well can we define the core, and how well can we define the oligemia or ischemia in the penumbral tissue. Again, cerebral blood flow can be computed. You can alter the threshold. You can be 30% less than normal, 34, 38, to assess in some situations where it is difficult to decide whether the patient is a good candidate for thrombectomy based on the ratios. So you could alter thresholds to be able to assess in a multidisciplinary fashion with the stroke neurologist, neurosurgeon, and the neurointerventionalists involved to decide whether the patient is a good candidate to go for endovascular thrombectomy. That way you can better inform the family, better inform the patient if they're comprehending the situation as to what are the outcomes, what are the risks, and what we can gain by doing the thrombectomy. So we'll move on to the angiogram. So this patient, as we established, is a good candidate. And here we see the right-sided internal carotid artery angiogram. And as we saw, I see a terminus here. This is the middle cerebral artery coursing towards the lateral aspect of the right cerebral hemisphere. Dead stop. Doesn't go beyond the M1, M2 junction. There is complete lack of perfusion in that area. The basal ganglia perforators that are coming off from this ICA terminus and A1 segment is kind of breathing air and getting some tissue to survive. And here the core is not big because their collateral circulations are large. There is retrograde flow from around other areas of the brain that are keeping the air-hungry brain tissue alive with a small core, as we saw on the other modalities of imaging on the CT scan. So we went in, we extracted the thrombus, and here is what we get. A breath of fresh air for the tissue that was air-hungry for a long time. And here you see how well the established perfusion is after you recanalize the vessel. This was a complete stop with a clot hanging in right there, completely occluding the vessel, and that has been extracted. Usually, if it happens, there is debate about how long does it take to open up a vessel. There are mechanical devices, stent retrievers. We'll take a look at that shortly, but it's difficult to go deep into those discussions. But just to say that it's not rosy all the time as this, that the clot comes out with one pass or one attempt, one suction attempt to extract the clot. Sometimes they're obstinate, they don't come out well, and complications happen. So all of that is part of life that we face. So this is what you want in most patients when you get an occluded vessel. Recanalization with first pass. The best outcomes are there when the clot comes out with the first pass effect. So here is to whet everybody's appetite, those who haven't had dinner. Sorry for the image of the clot, but this is the stent retriever and this is the long segment clot that comes out. This is an image here showing the stent. The stent device itself is pretty radiolucent. And you can see these dots. This is the segment of the middle cerebral artery, and the dots, the stent is opened up, is how you assess these dots. Usually are a single point. And as it comes out into a vessel, it opens up and the spot becomes separated, and you get 3 or 4 radio dense dots, which tell you that the stent has opened up well. And then we fix the clot with somewhere in middle of the stent, and then extract it with suction applied to the end of the catheters. So this is what we achieved. So we basically arrested the core tissue that had been damaged up to the point of time that the patient presented to us with these symptoms. So as we see on the follow-up CT scan, the caudate head, lentiform nucleus, lateral aspect is what has died. Basically, this low attenuation suggests that the core tissue has succumbed. It is replaced with gliosis, fluid-filled structure later on. As it matures, it'll be just fluid. And this tells you that rest of the brain is all salvaged. The penumbra that was hugely green, as we saw on the perfusion study, a large area, has been salvaged. And the patient did excellent from outcome point of view. And that is one of the things that I say to medical students who are deciding which branch of medicine to choose. There is nothing more exhilarating than getting an occluded vessel open and see the patient start to move the hemiplegic side on the table. So just to put it out there. So this is basically, by that example, I want to emphasize that in 2015, I call it the famous 5 randomized trials now. 5 randomized trials came out with overwhelming evidence, relative risk reduction and improvement in patient outcomes compared to conservative management in large vessel occlusions. And these trials are from across the world, from Canada, from Australia, from the UK, from the US, all showing benefit of thrombectomy in large vessel occlusion in improving patient function. Less than 4.5 hour window. Beyond 4.5 hours, 6 hours to up to 24 hours now, these 2 trials, DAWN and Diffuse 3, have added evidence, level 1 evidence, that even in late presenting strokes, like the case example that I showed, if the perfusion parameters are favorable, you pick up the patient based on those parameters, and favorable outcomes are obtained by doing thrombectomy. So now from famous 5 year, it's a magnificent 7, but there are multiple other trials. These are seminal trials which have established stroke thrombectomy on the map of stroke, basically, to improve patient outcomes. And these are the incredible devices, as I call them, the incredibles. They got FDA approved in 2012. CE mark approval was a couple of years earlier in Europe and the UK. And these are the stent-based devices. That is what we use to capture clots and retrieve them from inside the occluded blood vessel. This is, okay, another case. This is a young patient, young 40-something-year-old physician in our institution, and won't go into any more details about the patient, but presented to us with a low NI scale of 3, with just some clumsiness in the arm. His wife found him in bed with weakness on one side, and then thankfully got him to the hospital. And this is a rare scenario, in that there is dissections which happen, spontaneous dissections in the carotid artery. Typically at the bifurcation, this is the carotid bulb here on the right side. And you can see that beyond the carotid bulb, it's like a string of contrast that is going up and nothing beyond. Very difficult scenario. A patient was some aphasia and some weakness of the left hand, nothing more. So difficult to decide whether one should intervene, and there are not like established treatment techniques out there. But these are cases, if you select specific patients for treatment, you can get dramatic results. This patient, I think we salvaged function so that he could get back to his profession. So that is a tremendous sort of marvel of medicine nowadays. But dissections in blood vessels are difficult to treat. It is difficult to assess how far the dissections extend and how many stent-based devices you will need. The issue is not placing the stent. The technique is relatively straightforward. The problem is what comes with it. You cannot place stents in blood vessels without putting patients on dual antiplatelet therapy. If there is a large burden of ischemia, you are basically putting that tissue at threat of hemorrhage, hemorrhagic transformation of ischemic stroke. And the patient might be worse off by doing that. So we can open up blood vessels with stent-based devices, but it is not clear how we should select these patients better. So this jury's out on this particular type of situation, but I just wanted to share a nuance about MRI. Here on the CT angiogram, we're seeing there is decreased perfusion in that right side of the brain. And we can see here on diffusion weighted sequences on MRI, which is basically a sequence which picks up ischemia. You see these bright segments, bright spots in the insular area, in the opercular area. And these are suggestive that there is ischemia. There is hypoperfusion, there is ischemia. What we do with CT perfusion, we can do with MRI with flare and diffusion mismatch. This is a flare sequence on the right side of the screen. Left side is diffusion weighted image. We see these areas of brightness, but we don't see corresponding area of brightness on flare. That is suggestive of that you could, if you recanalize vessels or improve perfusion in this part of the brain, these diffusion bright areas will resolve. They are salvageable. That there is this sort of understanding in texts that once you get restricted diffusion on MRI, that tissue is not salvageable. I think that is false. This stroke imaging tells us that if the flare signal has not become bright, the diffusion weighted sequence or the diffusion weighted abnormality can be reversed. So this is further up in the patient's right side of the brain, which shows diffusion weighted abnormality. But again, no flare signal, corresponding signal abnormality. You can see slow flow in blood vessel being bright in these sulcal small blood vessels, which is a sort of a fascinating pickup, and then something to sort of for the radiology background trainees and people on the talk. It's something to sort of keep in mind that slow flow in blood vessel can be bright on flare. So we see the dissection on CT angiogram with a lot of discussion with stroke neurologists and the emergency department physicians and the patient. We decided to go ahead with treatment because his hand function is very, very important to him from a point of view of his profession. And it could be true for anybody, musicians, tailors. I mean, depends on what profession you're in and how badly the function will affect you. So those are the reasons why one takes the risk to treat and try to salvage brain tissue. So here we see lateral image showing the carotid bulb, ratty appearance of the internal carotid artery. There is flow beyond, which was not as well picked up on the CT angio, which is one of the sort of nuances that is not going to be discussed here because it's too detailed. But you can see the dissection flap. You can see a flap coming off from the wall, irregular with a little bit of clot and irregular flow into the true lumen of the internal carotid artery distal. So we decided to treat this. We gave the patient dual antiplatelets, some integralin during the procedure, and then you can see here, this is an angiographic image of that slow flow in the opercular sulcal blood vessel that we were seeing on the MRI on the flare sequences. You see these void areas. This is blood contrast percolating into those opercular branches, which is not perfusing well. And these are sort of, that is what I was trying to point out, why you see that bright signal on the flare sequence. So we went ahead and stented a couple of telescoped stents, and we have in our midst a giant in kind of like stent applications. Dr. Jameri, my colleague, he's a senior colleague. He does body intervention and neuro intervention. He knows stents as the back of his hand, so we were collaborating on this case. We put a couple of telescoped stents, as we see on this image, and we restored flow. So the dissection flap is tacked down onto the vessel wall. You can see some irregularities still here at the back, but the vessel is largely opened up compared to what it was before. And this patient is another image showing the flow to be better. We basically ballooned, dilated the stent a little bit to kind of apply it to the vessel wall a little bit better. And here you see restored flow. And the patient did improve gradually over a period of few months, was back doing what he loved to do in life, that is his profession, and is back working at our institution. So here you see the example, the diffusion weighted image before and after stenting, reversal of restricted diffusion in ischemic stroke after recanalization. It is kind of dispelling that myth that all restricted diffusion on stroke patients is non-reversible. That is not true. Here you see again, large area of diffusion weighted abnormality reversed. Diffusion weighted after recanalization is normalized. There is some area which is still restricted, and that has flare sequence correlation. So here on the flare, you can see that these areas are permanently damaged. So that appears as bright on flare sequences. FLAIR is, for non-radiology people, it's an acronym. It's fluid attenuated inversion recovery sequence. I can't get to more detail than that, but that allows fluid which is not freely flowing to be bright. So edema, ischemia, and slow flow in blood vessels will be bright on FLAIR sequences. So that is a little bit about the acute ischemic stroke, large vessel occlusion. Summary: large vessel occlusion is very important to pick up in emergency departments because stroke thrombectomy can transform lives, which they wouldn't if that was not offered to the patient. So that is now level 1 evidence, and all systems of care now are geared towards picking up those stroke patients early, getting them to neurointerventional departments where they can be safely recanalized. So moving on to the vasospasm section, which is subarachnoid hemorrhage, and too much sort of detail to cover, but I will give the salient points. Vasospasm happens in about 80 to 90% of patients with subarachnoid hemorrhage. That period is about from day 4 to 14, can be variable in individuals, but roughly in that 2-week period after subarachnoid hemorrhage, as we see on this non-contrast CT head with blood in the subarachnoid cisterns. It could be aneurysmal blood, it could be non-aneurysmal, it could be venous bleed, so many different reasons. And there is an entity where vasospasm can happen in idiopathic sort of drug-induced or drug-abused patients who can get vasospasms in the cerebral circulation. That can be salvaged. In the subarachnoid hemorrhage context, these patients are all in neuro ICU. They're having their vitals monitored, blood pressure, their pulmonary artery wedge pressures, all invasive vital sign monitoring is there, and neurological function is assessed every sort of 15 minutes to half an hour to pick up change. That is why they are in neuro ICU intensive care units, to pick up this change in neurological status, which will tell us which ones are symptomatic vasospasm patients. And because they can be salvaged, they can have intra-arterial infusion of spasmolytics, which are calcium channel inhibitors, and more recently, milrinone, which is an anti-hypertensive agent, which relaxes, has effect on these smooth muscle vessel walls, smooth muscles, which will improve vessel diameter and relax them to improve perfusion to the brain. So intra-arterially, we go up with a microcatheter or a catheter in the internal carotid. Sometimes we infuse right at the site of spasm. This is subarachnoid hemorrhage from an anterior communicating artery aneurysm, as we see here, projected in the midline. These are the A2 branches of the anterior cerebral artery. This is the A1 segment, and here is a big blob, which is the aneurysm, which we coiled acutely to restore or prevent risk of rehemorrhage. But in that patient at day 6, we see this ischemia in the anterior cerebral artery distribution on the pyramid line location here. And CT angiogram suggested there is decreased flow, and we brought the patient down for an angiogram. You can see the middle cerebral artery is spasmed out. Here, the anterior cerebral artery is also looking a little bit ratty. And then on the other side, you can see the anterior cerebral artery is like a string. The supraclinoid segment of the internal carotid artery is narrowed down. The middle cerebral artery is decreased in diameter. So quite a significant burden of vasospasm here. So we gave intra-arterial spasmolytics. The vessel diameter improved. The supraclinoid segment improved in diameter, as we see on these images, as my arrow is pointing out. And then on this lateral projection, you can see that there is still narrowing of the supraclinoid segment. Here's the anterior choroidal artery, posterior communicating arteries coming off from the ICA. And there, we try to assess how much do we need to, what risk every procedure, every microcatheter insertion into intracranial vessel has risk of dissection, risk of rupture. But we decide whether the patient's want of improved perfusion makes that risk worth taking. So for example, here, intra-arterial spasmolytics improve the diameter in the middle cerebral artery, but we can see still here that the supraclinoid segment of the ICA is still narrow. And that can be improved with balloon angioplasty. This is, you can see the coiled aneurysm here, anterior communicating artery coiled aneurysm. We have the microcatheter, and look at this, the balloon is inflated in the paraclinoid, supraclinoid segment of the internal carotid artery. And this is hazardous. I mean, these vessels are very fragile. The adventitia of intracranial cerebral vessels is non-existent. So you have the intima and a very thin layer of basement membrane. So balloon angioplasties can dissect vessels very, very easily. So not to be taken with a like a word of caution, but we do take that risk. We do take it to improve diameter of blood vessels, improve perfusion, because otherwise patients are going to stroke out. So here we see the diameter of the paraclinoid, supraclinoid vessel improved after the balloon angioplasty. The A1 segment is also improved with flow. Here was a stroke in the anterior cerebral artery distribution, but we are improving that flow by these mechanisms. Intra-arterial, spasmolytic, and balloon angioplasty. We see the improved diameter of the supraclinoid vessel here in the internal carotid artery. That is another example of pre-balloon, post-balloon, how it is smooth and improved in diameter. So that is what we can achieve in treatment for these patients who do have vasospasm. We have had subarachnoid hemorrhage patients come down 3 times, 4 times, twice a day sometime, because they spasm back. The blood is so irritant outside the blood vessels in the cisternal spaces that they spasm the blood vessels repeatedly. So that is why it is important to have the patients in neuro ICU where they can be monitored very, very closely and have a neurointerventionalist at hand who can go in and improve circulation as needed. Just a caveat here before we end the talk. CT angiograms are done, yes, with bolus chase, but it is of arterial contrast, but it is very important to know the background cardiac status of the patient. If there is a degree of heart failure, ejection fraction is low, contrast is not going to be pushed up as usual to the intracranial circulation. And you might get false sense of maybe spasm, maybe occlusion of vessels, as we see on these MIP images, but you can see there is distal perfusion of the vessels. These maximum intensity projections that we always get now with post-processed artificial intelligence and all sorts of automated softwares now that will pick up these and will sort of spew out that, oh, caution, there is vessel occlusion here or spasm here. That kind of software is coming. But a caveat is we are only limited by how much of interpretation we can achieve from the source images of the brain circulation. So it's always important to go back to the source image to look at whether there is good opacification on the venous side, on the arterial side, to be able to assess that, oh, okay, this could be a false representation. And that is very important to convey to the clinicians, because we got this patient down for angiogram based on these images, and lo and behold, the vessels are nicely open. There is no spasm at all. So it's important to not overcall these situations. So this is image of that patient who we were able to salvage and not a large burden of delayed ischemic stroke in these in the subarachnoid hemorrhage patient. So there I will end the talk and will be open to questions. We talked about a couple of neurointerventional emergencies in acute cerebral ischemia. We talked about large vessel occlusions, and we talked about vasospasm in the context of subarachnoid hemorrhage and how we can help some of these patients with treatment. Thank you.
Yeah, thank you, Dr. Neeraj. That is a good overview of three basic conditions, what we see day in and day out. We have some neurologists as well on board. You could chat or type in the chat box, or you could speak out. Dr. Atik is there and a couple of his colleagues. Before he talks, what would you think is the role of MR? Can MR replace CT as a one-stop modality to look both for infarct as well as hemorrhage using SWI and other sequences? What's your opinion?
Yes, that's a very good question. The issue is more, I think it is established that MR is better. The issue is resource. Where do these patients get the MR resource in the emergency department? That is the main thing. If we have the resource, definitely MR is better. MR is better, I would caution, for subarachnoid hemorrhage. Subarachnoid hemorrhages on MR may not be picked up in the hyperacute setting, but otherwise parenchymal hemorrhages definitely can be picked up. Vasospasms and ischemia, acute vessel occlusions, MR angiogram can be done. MR perfusion, this is that example that I was showing about the diffusion and the flare mismatch. MR has a tremendous role. Dr. Pam Schaefer from Mass General, she talks about that there is no need for perfusion. We just do MRI, we see the diffusion and flare mismatch, the patient goes for thrombectomy. If there is a large vessel occlusion on MR angiogram, we don't need perfusion because it's a secondary indicator. If the diffusion doesn't match with flare sequence, that means that area can be reversed, as we saw on the example that I showed you. So I think MRI has a tremendous role, even for intraparenchymal hemorrhages, to be able to risk stratify, look at blossoming of hemorrhages. CT is very crude. It is very crude, but it is very easily available. And it's the resource want for a CT scanner is much lower than an MR scanner. And in that context, our chair, Dr. Gulani and team, they're working on a 0.5 Tesla MR. How do you improve these sort of, I know, as we all know, that 0.5 Tesla doesn't produce good images. But how do you refine 0.5 Tesla MRIs to produce good images, which are clinically relevant, and you can take clinical decisions based on that? That'll be a huge advance from a resource point of view. A 0.5 Tesla MRI would be cheaper, and it can be arranged to be planted in a emergency department. So access, like UCLA has, Mass General has access to MRI in the acute setting. So they do, their paradigm is going straight to MRI. CT, again, I think still to exclude hemorrhage, maybe outside in the field when the paramedics are getting to the acute ischemic patient with large vessel occlusion or not, they can quickly assess whether there is bleeding or not. If there is no bleeding, TPA can be administered on the field, outside. So there is still role of CT scanners. Portable MRI scanners are coming, but it's still, it's in the future.
Yeah, since our department, our hospital is a low volume setting, we have the luxury of doing MR for all stroke patients. We do the
Fantastic.
stroke, alert from the ER, and our MR is just next to the ER. So they come and do a diffusion, and if there is, especially if they come within the window period, and the stroke neurologist is online as well here, Dr. Atik would add. So we have the luxury of performing MR. So some of the times we have picked up hematomas on MR, and then they go back to CT. And you always follow up with post thrombolysis with CT scans for hemorrhage and to know the extent of the infarct.
That's
Dr.
fantastic.
Baburaj
I think
is
it's
also,
nothing.
yeah, please go ahead.
No, I was just going to, sorry to interrupt. I was just going to say, it is fantastic to have that resource. We don't in the emergency department, we are trying to get an MRI scanner, but we're not there yet. So the MR access is more for patients who have allergy to iodine-based contrast, have anaphylaxis, and then those patients are got to the MR with rapid sort of assessment. And also in the pediatric stroke side, that's another huge topic. Pediatric ischemic stroke is underdiagnosed, and timing-wise also, CT is radiation. So you don't want to be doing repeated CT scans on pediatric patient group. MRI there is hugely important. You can assess large vessel occlusion without contrast. Arterial spin labeling now is getting there, as you will know, Dr. Nanduri, that you can do perfusion without contrast with arterial spin labeling. You can identify large vessel occlusions with arterial spin labeling. It's still not all established yet, but it's getting there. So pediatric ischemic stroke, it will be a huge, huge deal. CT will not be able to do anything there. MRI is the way to pick up other stroke mimics and not have the burden of radiation on pediatric stroke groups.
Yeah. Currently, one of our residents is doing a thesis dissertation on 3D ASL and SWI in evaluation of collateral circulation in acute ischemic stroke. So that's been 3D ASL is definitely coming into routine modality in our setting. And the second thing is, if a patient is clinically suspected of a posterior circulation stroke, do you still go ahead with the CT, or do you look for an MR in that setting?
Yeah, so posterior circulation is much poorly established than the anterior circulation. As we know, posterior circulation evidence is getting there too, but in posterior circulation, reliance on MRI to pick up ischemia. Because posterior circulation, as we know, the presentation is very vague. It's like dizziness, some sort of clumsiness, so vague symptoms. And there are people who are sent back from the emergency department, come back obtunded. Ambulance gets them back and they're obtunded with a basilar occlusion. It's a huge deal. I think very low threshold for imaging with MR is critical. Because if you see ischemia on MR, then you do the CT angio or you do MR angio, whichever, to pick up that basilar occlusion or something that can explain the patient's symptoms. So very, very important there. MR has a huge role in the posterior circulation.
Yeah, Dr. Baburaj is also there. Anything from Dr. Baburaj? There's a question in the chat box as well.
Yeah.
Doctor.
Combining, hang on a minute, I missed that. Cardiac imaging in hyper, okay. Yes, so stunned myocardium, I think that's what you're alluding to there, Dr. Kumar, right? Cardiac imaging, but what sort of cardiac imaging is what I would say. Are we trying to assess degree of stunned myocardium and heart failure, which can happen as a consequence of large burden of ischemic stroke? Yes, definitely. For stratification, where do you want, how much support does the patient need to augment cardiac function in those situations where there is stunned myocardium along with acute ischemic stroke, cerebral stroke. So there is definitely a role. If the patient is not improving, if the perfusion of the brain, if the vessels are open, But if the driver is not working well, then the cerebral perfusion will suffer. So how do you augment cardiac function in those